Good morning, and thank you for inviting me to talk about left atrial appendage today. I'm sorry I could not be there in person. I'm going to talk about left atrial appendage options and the journey that we went through in the last 10 to 15 years. The first clinical trial that was done on the first generation of Watchman looked at 2,621 patient years. It looked at ischemic stroke, hemorrhagic stroke, and also risk of stroke, cardiovascular death, and systemic embolism. In this study, which was a non-inferiority study, the device was non-inferior to oral anticoagulation therapy at that time, which was warfarin. However, there was a superiority on primary efficacy endpoint that was observed at 5 years. If you look at the 5-year result of the PROTECT, there was superior efficacy, reduced mortality, and similar overall safety as warfarin. Looking at a meta-analysis of PROTECT AF and PREVAIL, it showed similar all-cause stroke, less cardiovascular death compared with warfarin. And there was significant reduction in bleeding-related cost with Watchman in oral anticoagulation eligible patient. I have to say that PROTECT AF did not result in approval of Watchman initially, and then PREVAIL was done, and with the PROTECT AF and PREVAIL, the device was approved. And one of the reasons that initially it was not approved was the complication related to the procedure. Subsequently, other studies was done, this evolution trial, which was done in Europe, and it looked at 1,025 patients, and in this patient only 5 were not suitable. But when you are looking at these patients, you can see that majority of these patients were off anticoagulation therapy. As you can see, the oral anticoagulation therapy was on only on 27% initially post-implant, and after first discontinuation, there were only a small percentage of the patients who were on oral anticoagulation therapy, which was 6%. So majority of these patients were on single antiplatelet therapy or dual antiplatelet therapy. Looking at the evolution data and compare it to the historic risk reduction based on Chad's VASC score, there was 84% risk reduction of ischemic stroke and 85% risk reduction of ischemic stroke, TIA, and systemic embolism if these patients were not on anticoagulation. So it showed very good result. Based on HASBLED, there was about 50% risk reduction on major bleeding, even excluding the procedural risk. Subsequently, the second generation of Watchman, which was Watchman Flex, was evaluated. It was Pinnacle IDE study. It included 400 patients in 29 US sites, and it was one of the studies which was done very quickly because of the enthusiasm of operators to include patients. The post-procedural antithrombotic therapy was DOAC and aspirin for 45 days, followed by dual antiplatelet therapy for 6 months, and then aspirin indefinitely. The patients had TE at 45 days and at 1 year, and essentially the study was completed at 12 months. The primary safety endpoint was all-cause death, ischemic stroke, and systemic embolism, and they looked at efficacy endpoint as so that was primary safety endpoint. Primary efficacy endpoint was closure, which was defined by any peri-device leak of less than 5 millimeter by T at 12 months. And secondary efficacy endpoint was the occurrence of ischemic stroke or systemic embolism at 12 months from the time of enrollment. As you can see in this slide, the primary safety endpoint was very good, and essentially there were only 0.5% issue, which when you are comparing with the previous studies with the first generation of Watchman, Prevail or CAP, you can see that there is significant decrease in the risk of complication. It was only 2 out of 400. Furthermore, primary efficacy endpoint was reached in 100% of the patient. None of them had a leak more than 5 millimeter. The conclusion of the investigators at that time was that LAA closure with the second generation LAA closure device was associated with a very low incidence of adverse events and a high incidence of anatomic closure. As I mentioned, it was only, safety endpoint was only 0.5%, 2 out of 400 patients, and the second generation left atrial appendage closure device met the primary efficacy endpoint with a left atrial appendage closure incidence of 100% when it's defined by less than 5 millimeter peri-device leak. When you're looking at this patient in this study, majority of them were on apixaban, so about 1/5 were on rivaroxaban, but at discontinuation at 45 days, you can see that 96.2% of them were on dual antiplatelet therapy. And the percentage of patients which were remained on oral anticoagulation therapy was only about 1%. Furthermore, if you're looking at the discontinuation of oral anticoagulation in Pinnacle Flex, it was 96%, which was higher than Protect AF or Prevail. So this was, the Watchman was the only, the first device that was introduced to market in US, but subsequently the second device, Amplatz Amulet, had a randomized clinical trial. In this study, more than 1,800 patients were randomized, about 834 had Amulet, and the rest had Watchman. Some of them were excluded on both groups. It has to be mentioned that the Watchman was the first generation Watchman, so we are not comparing Amulet to Watchman Flex. In this study, the anticoagulation treatment from get-go for Amulet was dual antiplatelet therapy, whereas for Watchman was oral anticoagulation. And as you can see, majority of the patient on the Amulet arm were on dual antiplatelet therapy, whereas majority of the patient on Watchman were on oral anticoagulation. Other key points are the risk of device-related thrombus, which was statistically not different. TIA was statistically not different. Hemorrhagic stroke was a little bit higher in the Watchman, and all-cause death was not really statistically different. In patients who had device-related thrombus, 2 Watchman patients experienced ischemic stroke, whereas none of the Amulet patients did. But TIA and hemorrhagic stroke rate were similar between the groups. So all primary endpoints were met. There was closure at 45 days, which was 99% with Amulet and 97% with Watchman. I have to mention it's like any leak of less than 5 millimeter is considered as perfect closure. Safety at 12 months were very similar, and effectiveness at 18 months were very similar. Therefore, Amulet achieved superior closure over the Watchman device by this study, although it was a small percentage, and there was a reduced rate of post-procedural anticoagulation in Amulet group. The conclusion of the investigator was that the dual seal Amulet was superior with respect to LAA occlusion and non-inferior with respect of safety and effectiveness in patients with non-valvular atrial fibrillation compared to the first generation Watchman device. After these studies came out, then more and more operators started to use these devices. And of course, now we are using NCDR to report all of the outcomes in patients who received Watchman. So SURPASS study was a study that did analysis of more than 16,000 patients who received the Watchman Flex device, the second generation Watchman, between August of 2020 and March of 2021. Essentially, it was all of the patients who were in the registry with 2 years follow-up. What are the difference between Watchman and Watchman Flex? Watchman had larger size. The Watchman Flex has a larger size and shorter device, and it has dual anchor, and the end of it is not open, so it makes it much more safe to push it, whereas the first generation you really could not push the device in. And also it has greater number of struts and reduced metal exposure to decrease the risk of device-related thrombus. So it looked at safety endpoint, which was composite all-cause death, ischemic stroke, systemic embolism. It also looked at the effectiveness endpoint, which was occurrence of ischemic stroke or systemic embolism 24 months post-implant. And there were additional endpoints such as death, stroke, device-related thrombus, major bleeding, and so on and so forth. Out of this 16,446 patients, 2.4% were not implanted. The one that were implanted was 97.6%. The NCDR did not have good follow-up on 13% of them, and 45-day follow-up was seen in about 90% of them. If you're looking at the reason that it was not successful, anatomy was not conducted for implant in majority of those patients, and appendage was too small or large. Device associated thrombus, which was developed, was very, very small number of those patients. And when you are looking at the key events at discharge, the risk of death was 0.07%, stroke was 0.09%, ischemic stroke was 0.08%, and hemorrhagic stroke was 0.01%. There was no systemic embolism, and risk of major bleeding was about 1%. So really the risk is very reasonable in real life. And when you're looking at the pericardial effusion that requires surgical or percutaneous intervention at the time of discharge, it was 0.32%, and even at 45 days was 0.5%. And requiring surgery was 1 per 1,000. Now, if you are looking at rate of the closure, 95% of them did not have any leak. The leak between 0 to 3 millimeter was 3.8%, and between 3 to 5 millimeter was 0.9%. When they looked at it at 45 days, the leak increased, but still the large leaks, which was more than 5 millimeter, was only 0.4%. So essentially 99.6% had a leak of less than 5 millimeter. Comparison of Pinnacle Flex, which was done by a group of really experienced operators, and Surpass, which was done by everybody essentially, shows that there were very similar safety endpoint. All stroke was less, ischemic stroke was less, but all death was a little bit more. However, when you're looking at the no pre-device leak, it was really very, very similar. In summary, this included the largest number of Watchman Flex patients to date. If you're looking at the registry, the average age was 76, 40% were female, and 6.7% were non-white. Child's VASC was 4.8 plus minus 1.5, and Hasbled was 2.4 or higher. The risk of death was less than 0.1%, and the risk of stroke was 0.3%, and pericardial effusion that required intervention was 0.5%. The device-related thrombus in this study was 0.2%, and 95% of the patient had leak less than 3 millimeter, and 82% had no leak. So there was no difference in the occurrence of a stroke, major bleed, DRT, all-cause mortality in patients with short-term oral anticoagulation or dual antiplatelet therapy in this study, because at this point, a lot of people started to use dual antiplatelet therapy, and therefore the guidelines for Watchman Flex also changed. So now you have the choice between dual antiplatelet therapy for 6 months and then aspirin versus 45 days of DOAC followed by up to 6 months of dual antiplatelet therapy, and then single antiplatelet therapy by aspirin. Some operators looked at half-dose apixaban to see if there is any advantage over dual antiplatelet therapy. The idea was the risk of bleeding with dual antiplatelet therapy is significant, and maybe if you use half-dose apixaban, we will have better results, less risk of thrombosis and less risk of bleeding, and overall 555 patients were looked at. If you're looking at the data, you can see that the device-related thrombus was significantly lower in half-dose oral, half-dose DOAC, half-dose apixaban. The composite endpoint, there was a significant difference, and major bleeding was in favor of the half-dose. So the authors proposed, instead of using DOAC and aspirin, and then switch to aspirin and clopidogrel followed by aspirin, is to just use half-dose oral anticoagulation, apixaban and aspirin, and beyond 45 days, it would be half-dose oral anticoagulation. Now let's talk about the other issue that came up, which is device-related thrombus. When you are looking at the patient who had device-related thrombus, out of more than 1,700 patients who had successful implant, DRT was negative in about 1,674, and only 65 had device-related thrombus. When you're looking at the risk of stroke, of course, when you have device-related thrombus, the risk of a stroke or systemic embolism is higher in this group compared to one that did not have device-related thrombus. However, when you're looking at the historic CHA2DS2-VASc data and compare it to oral anticoagulation therapy, there is really not much of the difference if they were on oral anticoagulation therapy. What were essentially the risk factors for device-related thrombus from this study? It was history of previous TIA or CVA, permanent atrial fibrillation, vascular disease, higher LAA diameter, and low left ventricular ejection fraction. So device-related thrombus in this study was 3.74%, and stroke or systemic embolism was, as you can see with DRT, higher than without DRT. So following LAAO closure by Watchman, DRT was 3.7%, threefold increase in risk of CVA or systemic embolism, but DRT was not associated with increased risk of all-cause mortality, and part of the reason is that these patients had, if they had a stroke, it was smaller stroke and it was non-fatal. 75% of patients with DRT did not experience a thrombotic event, and DRT accounted for about 10% of all ischemic CVAs. The journey continues. The third generation of the Watchman came out. This is Watchman Flex Pro. What is the difference? Essentially, this device, we came with a larger device. We realized that there are some appendages which are too large to be closed with 35 millimeter device, so they came up with a 45 millimeter device, and they added a coating, antithrombotic coating to these devices to decrease the chance of device-related thrombus. If you're looking at these patients, now we have to see how effective it is. Now, peri-device leak was another thing that looked upon, and as you can see, different studies showed different degree of peri-device leak. What are the mechanism of the leak? The mechanism of the leak can be an edge leak or uncovered lobe, or it can be a fabric leak. So this is with Watchman devices. With double seal, you still can have leak between the disc and the lobe. You can have leak with distal LAA, and it can be an uncovered position that can cause leak, and of course fabric leak can happen with both devices. Looking at the follow-up of this patient with ischemic event, you can see that when they have no peri-device leak, the risk of having ischemic event is less than when they have a peri-device leak, and it's regardless of which device you are looking at. So if you're looking at the NCDR of LAAO with Flex or Amulet IDE, it looks like it would be similar. And what are the ways that we can close this leak, which is beyond the subject of this talk? Is the leak can be closed by delivering embolic coils. It can be closed by putting a second device next to the other device if it's uncovered lobe. It can be done a radiofrequency ablation to close it if it's a very small leak, or different plugs can be used to close these leaks when it's necessary. So this publication in 2023 from Journal American College of Cardiology looked at the leaks and came out with a certain guidelines. If there is a visible communication between LA and LAA, then diagnosis of peri-device leak is made. Then we are looking at the peri-device leak diameter. If it's small leak less than 3 millimeter, or if it's a small proximal LAA tissue, we can observe. If it's a significant leak, which was defined as between 3 to 5 millimeter or uncovered lobe, then we have to consider the bleeding risk. If the bleeding risk is prohibitive, then we are talking about the closure device, that if it's a narrow one, we can close with a coil or RFA, and if it's very wide, we need to use plugs or occluders. On the other hand, bleeding is not prohibitive, oral anticoagulation can be resumed and re-image. Now, if the other question is the LAA thrombosed? If the LAA is thrombosed and there is communication, then there is really nothing to be done. If the LAA is not thrombosed and it's incomplete LAA occlusion and it's only fabric leak, then we can observe. So this is the algorithm that they came out 2 years ago to deal with these leaks. Of course, some operator thinks that any leak is too much and needs to be fixed, but this is right now the consensus of what can be done. Now, the most exciting news end of last year in November was OPTION clinical trial study that everybody was waiting for. It was a study that looked at AFib ablation and Watchman that could be done concomitantly or sequentially versus AFib ablation and oral anticoagulation therapy. It was 1,600 patients with 3-year follow-up. The investigators looked at primary efficacy endpoint, which was stroke, all-cause mortality, and systemic embolism, primary safety endpoint, which was non-procedural bleeding, and secondary safety endpoint, which was major bleeding, including procedural bleeding. As you can see, that OPTION primary endpoint outcome showed non-inferiority of ablation plus Watchman to ablation plus oral anticoagulation therapy. Actually, ablation and Watchman did a little bit better on stroke, mortality, and systemic embolism, but it did not reach statistical significance for superiority, but it showed non-inferiority. When it comes to non-procedural bleeding, you can see significant difference between the two arms with advantage to ablation and Watchman over ablation and oral anticoagulation therapy. Looking at the primary efficacy endpoint components at 3 years follow-up, you can see that all-cause deaths, even cardiovascular death, non-cardiovascular death, all strokes, ischemic strokes, and hemorrhagic strokes, none of them shows any inferiority of the approach of AFib ablation and Watchman at the same time. When you're looking at the secondary safety endpoint, which is major bleeding, you can see that there is a 23% decrease by using combination of ablation and Watchman, including the pre-procedural bleed. Now, more recently, last month, the authors looked at the two groups of the Watchman. Some of them had a concomitant ablation, Watchman, and some of them had sequential. And as you can see, still, even when it was done concomitant, the safety and primary safety endpoint showed non-inferiority of concomitant devices compared to ablation and oral anticoagulation therapy. And with the sequential cohort, it showed the same thing. So regardless of if the procedure was done in the same setting or in 2 different days, there was a significant decrease in risk of bleeding, and there was no non-inferiority when it comes to primary endpoint, which was death, CVA, or systemic embolism. So this is putting it in the perspective. Ablation and Watchman had essentially was non-inferior to ablation and oral anticoagulation therapy, and was superior when it comes to non-procedural bleeding through 36 months, and again was non-inferior even when you're including the bleeding around the time of the procedure. In conclusion, multiple studies have shown efficacy and safety of dual antiplatelet therapy with Watchman and Amulet. Residual leak, do they matter, and how much is too much? Now we have at least some guidelines to go with it, and I think further data from NCDR may help us to put light on this matter. DRT, device-related thrombus, is associated with higher risk of ischemic events. However, majority of these patients remain asymptomatic. We need a better risk stratification for DRT and risk of ischemic events post-LAAO closure. Watchman Flex Pro has been coated with a thromboresistant coating that significantly decreases the risk of DRT. However, what kind of anticoagulation or antiplatelet needs to be done with this change needs to be further evaluated. Last but not least, option trial showed non-inferiority of Watchman to DOAC for all-cause mortality, stroke, or systemic embolism, and superiority for non-procedural bleeding at 36 months. Thank you very much for your attention.